These are the bony landmarks that we're going to see with lateral view. Definitely make sure that you're comfortable with viewing each of these. Definitely make sure you're very comfortable with identifying each of those structures. So like I said, the final examination is going to have a lot of labeling on it. So you want to make sure that you're very familiar with and comfortable with labeling those images. The one thing I want to note here is on the left hand side of the screen, you can see something called the supinator fat strip. That's going to be very key with identifying injury. The other one's going to be the anterior fat pad. So definitely understand how both of those look on plain film x-ray. Definitely understand why each of those are important when it comes to pathology of the elbow. So here again is the lateral view of the elbow. So what I would like you to do again is pause the slideshow presentation and be able to identify each of those. I will say that the nice thing about this picture is obviously we can identify via outline where the humerus is, where the radius is versus the ulna, but definitely make sure you understand where each of those structures are and that you're able to identify them. So moving on to the forearm, this is an AP view of the forearm. Again, understand that the forearm is in a supinated position, not a pronated position. That's obviously a position that's unique to the forearm, in that obviously we have a crossing or an overlap of the radius and ulna. So definitely make sure you understand that in an AP view, obviously the arm is going to be placed in the anatomic or the supinated position. These are the landmarks on the forearm that we're going to see in an AP view. Big thing to note here, and this is the part that trips a lot of people up, is understand which is the radius and understand which is the ulna. Very easy to do when we're looking at anatomic structures, if we're looking at a Netter's atlas, for example, but sometimes you can get a little confused on which is radius and which is ulna. So that's the first thing I would do, is identify which bone is which, and then from there, it's honestly pretty darn easy. If you just kind of remember and think about what structures and features each bone has, then it should be very easy to identify these structures. So again, there is a forearm AP view with some numbers and some labels on it. Again, what I'd like you to do, pause the slideshow presentation and blind yourself to those answers. Get very familiar and very comfortable with identifying those structures. So this is a forearm lateral view. So what we see here is obviously the elbow still bent at about 90 degrees to shoot that picture, and the picture shot from lateral to medial. So just be very comfortable in identifying what structures we're going to see on a lateral view. Also understand why we would use this lateral view. The big theme for this course has been one view is no view, right? So we want to make sure that we're taking multiple views at ideally a 90-degree tangent, so we obviously can identify not only the most number of structures, but also the depth and intensity of pathology when present. So obviously this is a picture and a view of an elbow and forearm at about 90 degrees, and this is going to be a lateral view. Understand here that we're going to have a little bit of overlap because of where the x-ray beam is coming from. So that overlap is obviously going to occur both at the proximal and the distal radial ulnar joints. So just be very comfortable with that. Also be very comfortable with identifying what structures we have. In order to identify an abnormal structure or pathology, we obviously need to first start with identifying what is a normal structure. So again, here's a labeled view of the lateral forearm. Again, pause the slideshow presentation, label the image, become very comfortable with labeling those images. Now moving on to an MRI of the elbow, obviously we get a much different view here. We also can see a lot of the soft tissue that we were not able to see before with a plain film radiograph. So definitely make sure you know what structures we can see, especially with this sort of view. Also be very comfortable with where the structures are located. So again, blind yourself to the answers. Get very comfortable with identifying structures, because I guarantee muscles like the supinator, muscles like the flexor series, muscles like pronator teres are all fair game for a final exam question. So this is another view of an MRI of the elbow. Obviously we're looking at a mid-sagittal or lateral view here. So take a look at this, compare this to the other elbow feature or the elbow picture that we saw. So take a look at the coronal view versus the lateral view. Understand which muscles are identifiable and which muscles are not. So we would need to understand in each of these views which structures we're going to be able to see and what structures we're not. So having a good understanding of anatomy and good understanding of anatomic placement will definitely help you with that process. So when looking at trauma, we're going to order or prefer radiographs for things like fractures, dislocations, subluxations. CT scans are going to be for more occult, complex, subtle things like osteochondral dissecans. MRIs, we're going to reserve those for soft tissue injury, but definitely understand the cost and the benefit of each of those. Definitely understand where we're going to use each of those imaging modalities and where each are most appropriate. So soft tissue signs that we're going to see on an x-ray. Now I know what you guys are thinking. It's x-ray, how can we see soft tissue signs? Well, remember that we do have soft tissues that we can see on x-ray, and we also are going to go through our ABCs, our ABCS system, every single time we evaluate a plain film radiograph. So two big ones that we're going to see are something called a positive fat pad sign. This goes by the eponymous Sale sign. We're also going to see something called an abnormal supinator line. So what we see here is that abnormal supinator line may occur if we are actually dealing with an elbow infection. So definitely something we need to know and something we need to screen for. So here's what a positive fat pad sign looks like. Obviously what you can see here is that anterior fat pad and the posterior fat pad have both pulled away from their normal line. So what you should see on a normal plain film radiograph is a very thin line. What we see here is we see almost like I said, a pulling away or a triangle in each of those. That's going to be identified as a positive fat pad sign. So we definitely need to make sure that we understand what that looks like on plain film radiograph. We also need to make sure we understand why that's important and what that can be a sign of. So these are supinator lines. What we see here on the left hand side of the screen is a normal supinator fat pad or supinator line. You can see it rides fairly close to the radius in the ulna. A raised supinator fat pad sign is going to obviously says what it is what it says. It is pulled away from that line of the radius in the ulna. This is a very difficult one to see and something that I definitely want to note in this coursework because it gets missed a lot of times. So we definitely need to make sure we understand how that fat pad line works and why it's important for our clinical examinations and correctly diagnosing our patients. So as the slide says, radial head fracture, most common fracture of the elbow. This is the fracture you're going to see more than anything else. And I can definitely tell you clinically, when it comes to elbow fractures, radial head fractures are definitely number one. So make sure we can identify that this patient has a radial head fracture. Definitely know what screening test we're going to use, being that elbow extension test, with ordering and actually accurately ordering diagnostic imaging. So be very comfortable with that and be able to identify this when we're dealing with plain film radiograph. Here's what a radial head fracture looks like in an MRI. So you can see a very thin area of white, almost a white line right at the radial head. You actually see two white lines because this actually has a multi-directional angle. So angle fracture, I should say. So let's make sure we understand how this fracture is located. Let's understand how this fracture is identified. So MRI can still be very valuable with looking at fracture, with looking at osteology and bone pathology if we need to. Here are osteochondral defects. So what we want to make sure here is that we can identify these osteochondral defects versus the fracture. So take a look at the left-hand side of the screen to get a good sense of what an OCD lesion looks like. And then take a look at the right-hand side of the screen, because not only are we dealing with an OCD lesion here, but we're also dealing with, on the ulnar side of the humerus, a fracture. So this is a good indication that there's obviously more than one pathology going on with the patient. Like I've told you many times, clinically, there's a lot going on with the patients. Rarely is it only one thing. So here's an OCD lesion on MRI. Obviously, much different story presented here. This looks very similar to me to the anterior ankle impingement that we looked at in the foot and the ankle series. So be very comfortable with identifying these sorts of lesions. Be very comfortable with recognizing that even if this lesion does not show up in plain film radiograph and your patient is still showing a significant amount of pain, lack of progression, pinpoint tenderness, things of that nature, then we definitely need to be very comfortable and proactive with ordering advanced imaging like an MRI or CT scan. So looking at forearm fractures, there are three classic fractures of the forearm. Now I understand that all three of these are eponyms, and this is a really good sense of why I don't like eponyms. Nightstick fracture is simply a fracture of the mid portion of the ulna. A Monteggia fracture is a fracture of the proximal ulna with the dislocation of the radial head. A Galeazzi fracture is a fracture of the distal radius with a dislocation of the ulnar head from the wrist. So definitely understand the three differences between those, because those terms are going to be very common on radiologist reports. So this is a nightstick fracture. So what we're looking at here is a mechanism of injury of a direct blow. I actually had a patient one time who I was seeing for a rotator cuff tear, and I asked him how he got hurt, and he said that he put his arm up overhead and someone hit him in the arm with a baseball bat, and he put his arm overhead to protect his head. And he actually did have a nightstick fracture, and even though I was seeing him for post-op rotator cuff tear, I definitely was proactive with getting him additional imaging of his forearm, and they were actually able to go in and do an RIF of his forearm, and the guy was a lot better off. But initially, it got undiagnosed because everyone was so concerned about his shoulder that they literally forgot about his forearm fracture. So this is a Monteggia fracture. So what we're looking at here is fracture of the proximal ulna with a dislocation of the radial head. So the big thing to note here is that if we don't see that radial head dislocation, then we don't have a Monteggia fracture. We have to have that dislocation of the radial head in order for this to be classified as a Monteggia fracture. If you don't see the dislocation of the radial head, then we're just dealing with a nightstick fracture, not a Monteggia fracture. This is a Galeazzi fracture. So what we're looking at here is a fracture of the distal radius with dislocation of the ulnar head from the wrist. Again, you have to have both symptoms or both signs present in order to diagnose this as a Galeazzi fracture. So this is the textbook definition of a Galeazzi fracture, but both of those qualifications have to be met. This is a green stick fracture. So green stick fracture is an incomplete fracture due to flexibility of young bones. So obviously pediatrics, adolescents are going to be the ones that have these fractures most commonly. So we can tell this is a pediatric forearm based on the epiphyseal plates. So we don't see a full epiphyseal line here, but we see a gapping of the epiphyseal plate.